Okay, let's talk a little bit about IVs. For your IV station, it doesn't have to be done perfectly in line with the station outline that you will find on the National Registry site. What they are looking for are competent advanced EMTs, not the advanced EMT's ability to regurgitate a linear-based information. So while I don't have the fancy IV arm that I made for you, I do have an attachable IV arm, and then I have all the materials that I'm going to need to start an IV. The first thing we do in this station is back to our medication rights of, is this for the right reason? Are we starting an IV for a warranted reason? In the case of National Registry, it'll likely be a hypotensive patient, but certainly any patient that would require some sort of intervention, cardiac arrest, sepsis, that would be our indications for starting IVs. Next, we want to move on to the medication. So it would seem like it'd be hard to confuse sodium chloride 0.9% or normal saline with another drug, but lactated ringers will come in a very similar apparatus as this, and it will say lactated ringers on it. Typically those will be written in blue to try to help the provider discern. But you can also have D5W in a bag such as this. So it's important to at least look and make sure we're delivering the right medication. In this case, I want to give normal saline. The next thing I want to do is make sure it's not expired. We never give a patient a drug that is expired. Even if it's not expired, I want to make sure that the fluid is clear. Normal saline especially does lend itself to crystallization, depending on what it's been exposed to, whether it's cold or extreme heat. So looking at it and just making sure that it's not cloudy or crystallized is also important. So once we know that this medication is safe to give to the patient, we're going to prepare the medication to be given. So we're going to remove the caps off. We've got a spike in our IV tubing. Make this so we can spike in our IV tubing, and then we've got the female end over here that we're going to be putting the spike into. So then we just push it. You're going to feel it pop through the plastic covering there, and then we're going to invert the bag. Now if you have the line shut off, no fluid's going to go through because the line is completely clamped down. As you move the roller bar to the top, the more the line is not clamped, which will allow the fluid to flow through. We want to see it where there's about either about a half, let's just say a half of your container right here filled up, so that you can still see where the drops will be falling from your bag, so that you can count drops if necessary when you're administering the medication to your patient. If you accidentally fill up this hub, which happens frequently, you can always invert the bag and squeeze out, and then that will release some of that fluid, and then you can always push more fluid back in depending on how much you need. But you do need to see that little needle. It used to be an actual needle, now it's just a plastic piece, so that you can count the drops. The other thing is we want to make sure our line is free of bubbles because we don't want to administer air into our patient's veins. And then we would set this up and say our medication's prepared. Now, every IV I start, I like to prepare in my own way, and you're going to develop your own way of doing things, and now is a great time to start that way. What I like to do is I like to prepare my tape. So I'll always pull my tape apart. This in this case is surgical tape. You probably will have plastic tape in your IV kits. And then sometimes I'll even strip it so I have smaller amounts of the tape like this. And then I just put it at the edge of the area that I'm going to be working on. This tape is going to go over the IV covering, so it does not need to remain sterile. For the Tegaderm, you can begin to pull it apart somewhat, but you don't want to pull it all the way off so the sticky part's exposed and put that down on any surface, because this part needs to remain clean. So what is nice though to do is just to bend back that top square part so that you have a nice easy grab and pull situation when it comes time to putting it on the patient. So perhaps you prepare your Tegaderm like that. You want to make sure that your extension tubing is not expired, and then you would have a saline flush, and you're going to just connect that to the tip of your extension tubing, and then you're going to flush out your extension tubing. This cap on the end should not be removed until you're about to put it into your patient, because you don't want this contaminated with anything. So that cap's gonna stay in there. And a good way I keep that sterile every time is I just leave the tail inside this plastic so that I know that it's going to be safe. You're gonna want some sort of cleaning agent, so I make sure that's ready. You're gonna want the appropriate sized IV. So in this case, I'm just using a 24 because I'm working on my IV arm. A 24 or 22 gauge is perfect for babies or small children. A 20 gauge for medium-sized children is appropriate, and then 18 or 16 for anyone who is truly sick and needs a large bore IV. These are the patients that need a lot of fluid very quickly. They need blood products. A trauma patient, you talk about going up to a 14 gauge, but moving more toward those lower numbers, the sicker the patient is and the older they are. Next, I always take my tourniquet out, give it a little stretch. That's just my habit. And then I'm going to tie it around. And on this, you may want to practice on tubing or something, because your very dearly made apparatuses that I made for you will not hold up to many tourniquet things. But you want to crisscross, pull taut one side, and then take that taut side and just tuck it under. So now you've got the loose side still hanging free. The tight side is now looped under with a little quick release knot. Then we're going to want to palpate for a vein, because you're not going to just stick it in there until you're more experienced and guess where the vein is. So I'm feeling for a vein, and then you want to cleanse the area and make sure that dries. Don't blow on it, don't rub it with air. When you expose the needle, you need to make sure that your partner knows that the needle is exposed. Get into the habit of saying, I'm starting an IV, or, needle-free something. Just because when you're moving around a lot, there is the chance that your partner falls on it. You don't want to contaminate him with something. Now that the IV site's cleaned, the big thing that I see students doing is they get their thumb in there and then they're trying to insert that needle over their thumb. And as you can see, that is already affecting the angle at which you are going to be pushing this into the patient. That's probably at least a 30-degree angle. And with peripheral veins, we want to go as flat as possible. We don't want that 30-degree angle. So work on getting that thumb out of the way. If you have people that you live with whom you can practice on just hand placement on their arm, that would be phenomenal. If I'm starting an IV on someone's hand, I always will grasp their fingers to hold them still, especially babies and children, you do that, but even adults are surprisingly wimpy at IV starts. And this will get my hand out of the way in order to be able to start that IV. So here, the same thing is true. If necessary, take your non-dominant hand and just pull some skin taut more proximal to where the site is that you're going. This will just help those veins pull a little tauter so they don't roll as much. The secret to when providers say, I couldn't get it because your veins rolled, is veins are more tending, I can't think of the word, they contribute more to rolling because they're round. So that's just a cop-out. So what we want to do is we want to pull the skin and the veins taut so that we have a good spot to enter to be able to access that vein. So our hand's going to be out of the way because we're more proximal or closer to the body from the site that we're starting it in. And then we're going to make sure our bevel is up. So again, the bevel is that area on the needle where it's been spliced at a 45-degree angle, where you see that nice little rounded area of the inside of the needle. And then we're going to hold it. I hold it between my middle finger and my thumb so that my index finger can just push it in. So that's left in control. And then I always keep my ring finger and my pinky up and away. I used to be a trumpet player, so I always go like this. Some people probably tuck it, but I'm cool. So here is my position of insertion. And then I'm going to find the vein. I'm going to insert. And you might have a little bit of an angle, as you can see, to get the bevel into the skin. I probably go up to 15 to 20 degrees, and then I bring it down. Because if you continue to go to the 15 to 20 degrees, you're going to go right through the vein and into the tissue underneath. So We're going to insert it into the skin, perhaps at an angle, but then we're going to level it out. And then we're just going to push it in until we see blood return into that hub. Once we see blood return, just give it a slight nudge. And I'm talking like less than a millimeter. So just so slight that it is, if you're thinking about just the tip of the IV being in there and you're trying to push it into that round part of the vein, maybe only the tip's in there. So you're just giving it just enough to push it fully into that circle. We don't want it to be on the wall of the vein and then slip out. So just the slightest of nudges, still see that the hub's full. And then I'm going to take, again, my pointer finger, and I'm just going to push the catheter in while pulling the needle out. And the fingers that we're holding, the middle finger and the thumb that we're holding this little in and outy apparatus, are still got my hands on there. My index finger is now working too. Pushing until I hear a click. Hopefully your catheter is all the way in, and then you're going to, let's see, what do I want you to do? I want you to occlude. So depending on the strength of your hands, you may want to occlude. I can occlude with my ring finger because it's strong enough. Some people need both the strength of their middle finger and their index finger to occlude any blood flowing out, and you will find that as you become more experienced. I would say right now, use your stronger fingers. If these two aren't strong enough, you can use your thumb. Your thumb is very strong. So bringing your hand around and then pushing down on that patient to occlude that vein is fine. Again, you want it just distal to the tip of this catheter. So you're not going to be able to occlude the catheter itself, but you just want it where the tissue of the catheter is on the end to squeeze that vein around it. So I am occluding this with my thumb, and then I am removing this. Now, what I encourage people who are new IV starters to do before flushing it, before doing anything else, is just to tape that sucker down. And I'm just taping it over the hub right there. That's a technique I also use with babies and children all the time because they are very, very, very good at ripping it out. Or I, as a provider, am good at accidentally ripping it out. But as a new person, even with an adult, it's good to get that tape down just to add a little more security to your IV site. Again, we're occluding while we're taping. If you start having a mess, put a towel under you. It's good as a new IV starter just to put a towel on your lap for a while because we all have bleed outs till we get more proficient at what we're doing. Now that I've got it taped and secured, I'm going to remove this. I'm going to take off the cap. If I'm still occluding, you maybe stick this out and ask the EMT to twist that out, put it down. Some people can develop a method, and while you're bored at home right now, you can sure do it too. They can stick this into this hand and twist and get it out. However you do it, just make sure this tip stays sterile. And then we're gonna push it in for the male end into the female end. We're gonna push the little cap down and just give it a little twist. You don't have to do it so tight that a child can't unscrew it, because you can in fact over tighten it and then require hemostats to untighten it, which becomes a pain in the butt. So just tight enough that there's no leaking, and sometimes it will become loose and you'll notice fluid flowing around the site. You just retighten it again. Then we want to make sure our tourniquet is released at some point, and we're going to want to just push slowly, and I'm talking like 1 mil over 5 seconds at first, just to look and see if there's any of that swelling, extravasation, reddening of the skin, making sure our IV's patent. If you're questioning it, you can pull back and draw black blood into your syringe. Just know that sometimes an IV can be patent and not get return blood flow, and this is because their vasculature is just collapsing around the end of that catheter. So we may not be able to draw blood, but then when we're infusing our fluid into the vein, it's not swelling, so we can depend on the fact that it's likely patent. Then you're going to disconnect it. We're going to take our fluid and we're just going to put the male and the female again and twist, and then we're going to give them the appropriate amount of fluid bolus. For an average adult, it's 250 to 500, sometimes up to a liter if they're healthy. We don't want to give heart failure patients too much fluid at once, so we're going to want to give it to them slower, but just give them a good amount of fluid to fix the problem that we're trying to fix. If it's in the case of dehydration, they've been vomiting for a couple days, a liter of fluid is fine, but making sure we're giving an appropriate amount for them. Again, for kids, it's always going to be 20 mils per kilo anytime we're doing a bolus. You don't ever guess that because you can harm a child. So always make sure you get the appropriate amount of the fluid.